Welcome to my final assignment for NURS 2514. My name is Montana Fragomeni, and I am a second-year nursing student at the University of Manitoba. Throughout this presentation, I will focus on the concept of intracranial regulation, the exemplar condition of subarachnoid hemorrhage, and the drug mannitol. Intracranial regulation is defined by Giddens as the mechanisms or conditions which impact intracranial processing and function. Because the brain plays a key role in intracranial regulation, it is important to note the major anatomical structures located within the brain: the cerebrum, the diencephalon, which consists of the thalamus and hypothalamus, the cerebellum, and the brainstem, which is continuous with the spinal cord and includes the midbrain, the pons, and the medulla. Normal intracranial regulation is highly dependent on the interactions which occur between and among each of these structures. We will now focus on the concepts which are closely related to the concept of intracranial regulation and examine how altered intracranial regulation has the potential to affect each of the following. 1. Cognition. When intracranial regulation is disrupted, subsequent impairment of cognitive function may occur. 2. Mobility. Because the brain is responsible for movement, coordination, and balance, when intracranial regulation is disrupted, an individual may experience immobility or an inability to initiate or execute purposeful movements. 3. Perfusion. Inadequate perfusion of oxygen and nutrient-rich blood results in the inability of neurons to function and thus in altered intracranial regulation. Finally, 4. Because the hypothalamus and pituitary glands, which play a significant role in hormonal regulation, are located within the brain, damage to these structures as a result of altered intracranial regulation may have disastrous effects on hormonal regulation. Subarachnoid hemorrhage is one type of hemorrhagic cerebrovascular accident, which is a localized infarction of brain tissue resulting from a lack of blood flow. Recall that there are 3 layers of protective membranes which surround the brain and spinal cord: the dura mater, the arachnoid mater, and the pia mater. Subarachnoid hemorrhage involves a bleed into the subarachnoid space, which is the area located between the arachnoid mater and the pia mater membranes of the brain. According to Lewis et al., the cranium can be thought of as a closed box, which is comprised of 3 essential compartments: brain tissue, blood, and cerebrospinal fluid. Under normal conditions, the volume of each compartment is relatively stable, and thus intracranial pressure is maintained within normal limits. If the volume in any one of these 3 components increases and the volume from another component is displaced, referred to as compensation, the total intracranial volume will remain the same, and thus intracranial pressure will remain within normal limits. This is referred to as the Monro-Kelly hypothesis. In contrast, if the volume of any one of these 3 components increases without a subsequent decrease in another component, the result is increased intracranial pressure. The intracranial pressure-volume curve is used to depict the relationship between pressure and volume within the cranium. This curve is affected by the compliance of the brain, which is defined as the brain's expandability, or the ability of the brain to buffer an increase in intracranial volume while avoiding an increase in intracranial pressure. It is represented as the volume increase, measured in milliliters, for each unit increase in pressure, measured in millimeters of mercury. The pressure-volume curve can be used to represent each stage of increased intracranial pressure, as is seen on the slide. Ultimately, increased intracranial pressure is a life-threatening situation which contributes to the pathophysiology of subarachnoid hemorrhage and the resulting complications which may occur. Subarachnoid hemorrhage is most often caused by the rupture of a cerebral aneurysm. These aneurysms are named based on their shape and may be described as a berry aneurysm, saccular aneurysm, or fusiform aneurysm. Approximately 25% of people who suffer from a hemorrhagic stroke, which is attributed to a ruptured aneurysm, die, while 50% of survivors are faced with persistent neurological deficits. It is also important to note that the incidence of subarachnoid hemorrhage caused by ruptured aneurysm increases with age and more commonly occurs in women than in men. Other causes may include head trauma, use of illicit drugs such as cocaine, and arteriovenous malformation, which is a congenital tangle of arteries and veins within the brain. If caused by the rupture of a cerebral aneurysm, the patient may experience warning signs in the following instances: if the aneurysm applies pressure to brain tissue, or if an aneurysm leaks prior to rupture. However, cerebral aneurysms are most often viewed as a silent killer because patients do not usually experience any warning signs until rupture has occurred. One of the most common manifestations of subarachnoid hemorrhage is the sudden onset of a severe headache, which is often described as being the worst headache of one's life and may lead to the symptoms of nausea and vomiting. In addition, a patient may experience alteration in level of consciousness ranging from alert to comatose, depending on the severity of the bleed. Other manifestations may include neurological deficits, seizures, and stiff neck. One complication of subarachnoid hemorrhage caused by the rupture of an aneurysm is rebleeding, meaning that the aneurysm has the potential to bleed or hemorrhage again once it has sealed itself and before surgery or other therapy has been initiated. Another complication of aneurysmal subarachnoid hemorrhage is cerebral vasospasm, which involves the narrowing of large vessels located at the base of the brain and may result in cerebral infarction. Other complications may include hydrocephalus, which is the accumulation of cerebrospinal fluid within the ventricles of the brain, and seizures. When a patient presents with an altered level of consciousness, it is important to assess blood glucose levels, as both hypo and hyperglycemia may present with signs and symptoms which are similar to those of stroke. In addition, it is important to obtain a complete set of vital signs in order to assess for the following abnormalities, which are indicative of increased intracranial pressure and thus of hemorrhagic stroke: hypertension with a widening pulse pressure, bradycardia with a full and bounding pulse, and an irregular respiratory pattern, referred to as Cheyne-Stokes respirations. These manifestations are referred to as the Cushing's reflex. It is also important to perform a neurological assessment on the patient, including assessment of level of consciousness, alertness, orientation, motor function, and pupillary response. This may be done using a Glasgow Coma Scale. When manifestations of a stroke occur, diagnostic studies are used to 1. Confirm that it is a stroke and not some other brain injury, and 2. To identify the likely cause of the stroke. Brain imaging is the single most important diagnostic study used in the diagnosis of stroke. MRI and CT scan are the most commonly used brain imaging tools. Since CT scan is quick and easily accessible in most facilities, it is the preferred method of brain imaging. It should ideally be performed within 25 minutes of symptom onset and should be read within 45 minutes of symptom onset. It is useful in determining the size and location of the lesion and helps to differentiate between ischemic and hemorrhagic stroke. Mannitol is an osmotic diuretic which increases the loss of water from the body through osmosis. It promotes diuresis in the kidneys by increasing the concentration of glomerular filtrate and increasing the osmotic pressure in the renal tubules, which blocks the reabsorption of water, resulting in a subsequent decrease in intracranial pressure. Commonly reported side effects of mannitol include headache, dizziness, nausea, vomiting, runny nose, dry mouth, and cough. Other side effects, which are rare but fatal should they occur, include seizures, rebound, increased intracranial pressure, tachycardia, heart failure, circulatory overload, and acidosis. Important nursing implications related to the use of mannitol include assessment of neurological status, measurement of blood pressure before and throughout treatment, continuous assessment of fluid and electrolyte balance, and monitoring of any signs or symptoms which may be indicative of dehydration.